Hi, my name's Paula Bennett and I lead the Utilisation Management Unit here at Health Innovation Manchester. And we're a team of analysts and clinicians, and we provide urgent and emergency care improvement support across Greater Manchester and beyond. So we're at that time of year now where there's an increased focus on urgent and emergency care. And we talk about winter pressures, but actually we're experiencing those pressures all year round. Perhaps 10 years ago, we definitely had increased pressure in winter, but during the summer months we weren't as busy. But now we feel that busyness all the year round. And what are winter pressures? Well, during the winter months we do see different case mixes of patients. We see flu, we see norovirus, the winter vomiting bug, and we see some of the effects of cold weather. That might be snow or just a reduction in temperatures. And the pressure that we feel is that the demand for health services, whether that's in primary or emergency care, outstrips our supply. So that might be the supply of cubicles in the emergency department, the supply of appointments in a GP surgery, or the supply of staff to provide care and assessment. I think another thing that's really important to consider as we're kind of heading really into the middle of winter is around utilising all the therapy staff that are available in your locality, whether that's in the community or the hospital. And I'm particularly thinking about their early care and assessment of frail older patients. We know that the older you are, the more likely you are to be admitted to hospital, and with increasing age your length of stay increases. We know in Manchester that if you're over 18 admitted to hospital, your length of stay can be around 8 or 9 days. And we also know that once you're over your acute phase of illness and you no longer require acute hospital treatment, that there are harms associated with increased length of stay in hospital. We call it deconditioning. And those harms reduce confidence, they reduce mobility, they reduce people's ability to provide their own care, and they also expose older patients to some of the risks of being in hospital, to infections and to falls. So the earlier patients can be assessed, and that might be right at the front door in the emergency department. We've got frailty services that can assess patients within an hour or two of arriving, and then work with community teams to think about a plan to enable the patient to be discharged as soon as possible. That's really important, really good quality assessment for patients, and enables them to get home as soon as possible. I want to talk a little bit more about data and how powerful that can be, how it can describe the reality of what's happening and also support planning. And in particular, the use of predictive data is really important. If we plan based on averages, then 50% of the time we won't have enough resource to meet the demand. Whereas if we use predictive data that's mapped to season and day of the week, then we're much better armed with information about what's likely to happen during the subsequent hours, days and weeks. So the Utilisation Management Unit here at Health Innovation Manchester have got over a decade's experience in urgent and emergency care. We're a team of clinicians and analysts, and we can provide bespoke support to localities, community and hospital systems to help redesign services. We use data as the basis and the platform against which to describe the current status of a service or a system. So the data to provide that baseline, where are we at now, and then to work with localities and all the stakeholders to think about the future state and what do we want this service or system or this patient pathway to look like in the future. So data for improvement, not for blame, to use it as a powerful tool to get messages out into the system. I suppose to create some discomfort in some situations with how services are currently constructed and when they're available for patients and when they might not be. And then we work with systems and stakeholders to think about how that service, that pathway might be redesigned in the future.